Well, good evening, everyone. This is Shankar Poncelet, one of your chapter leaders. And just give me a thumbs up in the general chat so I can know that you can all hear me or not. All right, I see thumbs ups. Awesome. So first of all, I want to say that I am extremely proud that we as a San Antonio chapter have won the chapter award of the year, essentially, with what we do here with the San Antonio Free Market Medical Association. And I really want to say that this is a community effort. We could not be what we are without all of you, without your support, without the sponsors, and without you actually showing up and showing an interest in what we're doing. A little bit of housekeeping. You see this app is pretty standard to what today's online meeting apps look like. To your right-hand side, you will find a general chat. You can also you have the ability, I believe, to message people personally. Definitely also don't neglect the networking aspect of this. And then there's also a Q&A feature that you probably know from other apps where you can submit your questions and then upvote and downvote. We're going to try and not interrupt the presentation unless the speaker asks for it. But generally, it is much easier to get to questions towards the end, which we will gladly do. I also want to emphasize that if you go to San Antonio FMMA.org, you can join our chapter as a chapter member for free. The local chapter membership is for free, and the national membership comes with a fee. And of course, also with benefits such as having a listing in Shop Health and a lot more. But for the purposes of being in touch with our chapter, to get the text messages, to get the emails, please consider joining as a free member if you are not already. The agenda tonight, will briefly hear from our sponsors, and then our co-chapter leader, Dr. Roger Muchigemba, will address basically the vision of what we're trying to do here. And then we have our main presentation by Dr. Phil Eskew. So I'm going to go straight into talking about the first sponsor with this, which is my company, Shankx. And I was recently asked, so you help doctors grow? And I think that is the perfect way of really describing that. We do have a program, Shankx.healthcare. If you go there, that's one of those new URLs, Shankx.healthcare. You can find more information about what we offer. The next sponsor that I want to highlight is DirectMed Clinic. Definitely always there to support with Dr. Roger as one of the chapter leaders, and he will talk more about that later. And I'm going to blend in a short video from our sponsor, Eagle Care Health Solutions. What they do is they equip brokers who want to start offering free market alternatives to employers and individuals. They equip brokers to do that. They help them do that. So I'm going to play a short video so you can see what that is about. And then we have Callie Badgett, who is a representative of the company. We have her in attendance, so definitely contact her if you want to know more about Eagle Care Health Solutions.
A product like Eagle Care Health Solutions is that the compensation program is so great that it gives me extra time to pursue my hobbies and travel quite a bit. My wife and I actually visited Hawaii 3 times in the last 12 months. It's been a game changer for us. Eagle Care Health Solutions changed our life, and we're looking to help others change their lives too. Today we have a couple of sirloin steaks. We got some chicken breast, some beautiful bacon wrapped pork, got 4 briskets on there, some asparagus, some peppers, got a number of different items over here for our vegan friends over here. Got some mango, If you ever had smoked mango, you've missed out. I got some pineapple, also got some skewers here with some squash and different kind of peppers. Of course, everything's better wrapped in bacon, so we got some bacon wrapped shrimp, and then also got some jalapeno peppers with cream cheese. Great variety of things that we're going to enjoy later. Become an EagleCare Health Solutions broker partner today. Schedule your broker intro meeting at eaglecarehealth.com/broker.
Okay, you see a very appealing video, lots of fun there with Eagle Care, and don't forget to message Kali if you are interested in that. Next up, I'm going to bring to the stage Robert, and he will tell us what RxBenefits is all about.
Awesome. Let me share my screen real fast. Okay, so really quick, what RxBenefits is, we're trying to come in and help the mid-market self-funded groups and companies actually control and manage their pharmacy spend, right? Because it's pretty out of control. We're not a PBM, we're not a TBA, we're not a coalition, but what we do is we only work with the mid-market groups that are self-funded. And it's really, we're independent. So when we say that, we don't keep any of the spread. We don't keep the rebates. We actually pass 100% of that right back to the companies and the groups. And so a lot of times the pharmacies, the PBMs, they have some misaligned goals, right? Because every time the PBM actually fills a prescription, they get paid. And so there's a lot of drugs out there that, even you as doctors don't really necessarily maybe know the cost. That can be thousands and thousands of dollars. So we kind of come in and help the companies manage that whole piece. And what we do is we have about 3 million members all across the country. We process now over $3 billion a year in pharmacy spend. And so what we've done is we actually have agreements with the 3 largest PBMs out there, which is CVS, Optum, and Express Scripts. And what we've actually done is said, okay, we're going to actually go out. We're going to leverage our company of 3 million people and 3 million members and price it like that. So we're basically getting the Fortune 10 pricing. We're passing that straight back onto our clients. So just a quick example, we actually just worked on a deal in San Antonio last week. It's about 400 employees in the group, I think 650-ish members total. They were actually already on CVS. And so we came in and showed them, hey, leveraging our network, leveraging our contract, we saved them 48% on their pharmacy spend. Same formulary, nothing changed, still CVS, but because we have such large volume and numbers, everything in pharmacy is really on the scale and the size of what you can do. So we come in and help do that. On average, first year savings for our clients are probably 25 to 30% on the pharmacy. But really what we really pride ourselves on is we have a bunch of independent clinical programs to help the company. So the PBMs do a lot of things well. Usually independent clinical is not one of them. So we actually come in and do that. So we've gone and got a bunch of what we consider low clinical value drugs, stuff like Duexis and things like that are basically over-the-counter combination of medication. And so instead of spending thousands of dollars, we can help them, the plans get off that. So maybe they're spending $30-$40. So we put in a bunch of independent clinical things. We have high dollar claim reviews. So anytime a patient has a drug that's more than $1,000, we have an internal PharmD team that actually flags it, make sure, is it appropriate? Is that the right piece? Is that the right diagnosis? And then we just added something new this year. It's complex condition intervention. So for these really high dollar specialty drugs, usually $250,000 and up, when those kind of get flagged across the radar, we actually start working with independent MDs that are specialists in that field to make sure that's appropriate and make sure it's the right diagnosis. And so kind of what we do just from a really high level is we have our contracts. That's where we're saving probably 20 to 30% off the clients. We have clinical oversight that's independent of the PBMs to kind of help keep the trend low, make sure the drugs are being appropriately dispersed. We have some catastrophic claim coverage, and then we put in some specialty pieces. And so really, at the end of the day, what we're just trying to do is we're trying to help the companies really protect the health plan, because especially if you're self-funded, you get a couple couple drugs that can really knock it out of the park for you, and that's going to really make it really difficult. It's going to really increase the rates. So again, all we really are doing is we're leveraging a 3 million member group to drive savings, drive scale, help the clients to actually save a bunch of money, and make sure that the members and the employees are actually getting the correct dosage, the correct medication, everything they need, and still keeping the health plan safe. So we've been around for over 25 years. We're in every state, and that's kind of just the high level. I don't want to take up too much time because I know we're all looking forward to the main presentation.
All right. Well, thank you, Robert, for your presentation, and thank you for staying on track. I know that that's not always too easy to do that, but I really appreciate that. I'm going to hide you from stage now. And don't forget, you all get in touch with Robert to learn more if that is something that you're interested in. I have, by the way, I have met Robert on LinkedIn because, as you may know, I'm live very often together with Dr. Roger, and I just cannot stop talking about this amazing movement. So definitely connect with me on LinkedIn if you have not done so already. It's very, very powerful. And if this is something you want to get into, also talk to me more. Next up is our co-chapter leader, Dr. Roger Mochigemba, and I have to bring him on stage here. Dr. Mochigemba, mostly known as Dr. Roger, is very passionate about creating that local network and hopefully eventually a regional and national network that helps all of us do a better job in an even better job in free market medicine. Dr. Roger, turn on your camera and your mic, and the floor is yours.
All right. Thank you, Shankar. And before I forget, let me just say thank you to you as my co-founder of this chapter. It's been a wonderful ride. And every time we get together and do this, we get more excited because we can see the traction that we're getting here. And as Shankar mentioned, that we were the chapter of the year this year at the annual FMMA meeting. So our goal here for San Antonio is to bring together some providers, to bring together the payers of healthcare, which is mostly employers, and then some brokers that know how to, that are looking for innovative and cost-effective ways to provide better, affordable care for their clients. So if we can bring together those three parties, and of course the other ancillary organizations like pharmacy, if we can do that in this community, then we're bringing value to the community and we're providing affordable health care because we're promoting transparency, and it works. People have benefited from this, and it's a good feeling to know that. So that's what we're all about. That's what we're trying to do here in this local market. And if we can be a model for providing that kind of value here, then it's my wish and prayer that that can be duplicated across the country. And with the parent corporation, the national organization FMMA, then we have a platform to get that done. So we're happy that you all could join and spread the word, bring your friends, tell people about what we're doing, and join our local chapter. I'm not going to take up much more time. I'm excited to hear from Dr. Eskew.
Yes, keyboard Dr. Askew, and I will bring him on stage here in a moment. Dr. Askew, be prepared to accept the invite. I have met Dr. Askew for the first time when I was at a conference in Chicago, and I knew very, very little about DPC. And Dr. Askew just has this gift of taking very complex topics and breaking them down so that we all can use and hopefully also sometimes leverage legislation and do a better job in serving our patients. Tonight's presentation will be very, very helpful for all of you, those at the very beginning, but also those who have been in this for a while and are looking to deal with a few tricky things. Just 3 keywords: the definition of DPC, dispensing of medication in Texas, Medicaid patients. I'm sure just these 3 keywords will kind of bring up so many questions for you. And with no further ado, the virtual floor is yours, Dr. Askew.
Thank you, Shankar. I'm going to do the presentation mode here, share screen, and we'll go with 2. And then when I click this button, hopefully you'll see the entire presentation. Okay. And hopefully that's working as intended, and you see a clean slideshow there. So we're going to cover several different topics, and I tried to go through and make sure the focus is going to be on Texas specifically rather than the entire country to the extent we can. So all that stuff's been saved elsewhere in other slide decks and other presentations that are recorded. So what will we focus on today? How does Texas define direct primary care, and how might that differ a little bit from what you see in other states? What does dispensing medications look like in Texas? It's mostly non-existent, but there are some weird loopholes, especially if you're a resident planning your future practice and you're debating your location. This could prove quite handy for you. Right? Can you privately contract with a Medicaid patient in Texas? And it looks like the answer is yes. And the answer is often yes in most states, except for Kentucky and Colorado. But in Texas, it might be a little easier than others. What does medical malpractice look like in Texas, and how is that different? We'll go over some non-compete issues, enforcement issues in Texas compared to other states, and then look at some Texas Medical Board history as well. And then if we have time at the end, we'll cover a few federal tax law questions. Those things always seem to come up, and then talk about in general how those can impact your practice going forward. So how does Texas define DPC? Well, they started defining it in May of 2015. They became the 13th state to pass DPC defining legislation. And this can be found in this Texas Occupations Code, Chapter 162, Subchapter F. So it requires that a DPC practice be broader scope, which is kind of interesting. And I can pull up the, let me do this. Let me get out of here real quick. I'm going to pull up that subchapter F because I had that saved. There we go. And move that over here. So it's not, this is the entire DPC defining law in Texas. It's not a massive piece of legislation by any means, but they say a direct fee means a fee charged by a physician to a patient or a patient's designee for primary care medical services. So I highlighted that because you're going to start asking, well, how did they define those things? And the agreement has to be between the patient, the employer, or, so it's an or their legal representative. So a lot of states, you have to have the patient sign the agreement one-on-one, even if the employer is paying. Not necessarily the case in Texas. So I've sort of highlighted that you could have the agreement with the employer and really not have a one-on-one agreement with the patient. I still think it's a good idea to do that kind of thing. In some circumstances, they might work for the employer for a certain time period and then quit. And in that scenario, they actually have a right to remain a member of the practice for up to 18 months due to COBRA rules anyway. You'd probably want to keep them as a patient, but even if you didn't necessarily want to, even if it was only open to employees, you have to give them the chance to stay on. So that's an important distinction to note, even though state law doesn't seem to require it. From a federal benefits law, federal benefits plan standpoint, you probably do want to have an agreement with the patient. The physician could include a professional association or professional limited liability company. So that's how they define the term physician. It's actually quite broad in this law. But a lot of people might look at this at first glance and say, well, what about a nurse practitioner or a PA? In Texas, they could not open their own practice and call it DPC, apparently. There are some that appear to do that, and I suspect they're their legal structure is one such that they're a professional association or PLLC. And in Texas, you have to have a physician that's sort of heading one of those things. There can be arrangements for partial ownership with PAs and NPs. It's got to be a primary care medical service, and Texas has an interesting definition there. So that's where I have the slide deck, and I'll pull this back up in a minute to kind of walk through this portion of the law. But the point is, you have to cover prevention and wellness in order to meet their definition of primary medical care service, and you have to be diagnosing and treating an acute or chronic disease, not necessarily both, which was interesting, and it has to be over some period of time. So that's how that kind of shakes out from a legal dissection standpoint. You can't work in workers' comp even if you wanted to. Texas wants you to carve that out. Some states don't care if you include this in the monthly fee. Others ask you to ghost claim, so you can kind of include the charge in the monthly fee, but they still want you to do some $0 claim so that they can track the workers' compensation claim. And then some states are more like Texas, where they say, we really don't want you to put any of that in there. You got to keep doing that on some kind of standard state-based fee-for-service basis. Okay. And we'll move past that unless there are questions later. So I'm going to move the slideshow back over and put that into presentation mode. So Texas law requires DPCs to be broad scope. So that's the piece we just went through. You've got the ors and the ands there. So this is kind of there for your reference. And that was my dissection of the broad scope portion of their law. And we talked about the workers' comp. That does include a provision that at first glance is probably more popular than it maybe ought to be. Most states don't specifically state this, but in Texas, an insurance company or a hospital system is prohibited from discriminating against a DPC, a patient, or physician, but they've got the word solely in there, which makes the burden of proving this fairly high. So if you feel like you're being discriminated against by a hospital because you're a DPC physician, you could pursue that under this law, but you got to prove that it's just based on that, and odds are they could find something else to point to as the basis for their discrimination. Okay, and we talked about the ownership piece. Texas professional associations can only be formed by physicians, podiatrists, mental health professionals, optometrists, and so on. A licensed physician assistant can jointly own a professional association with a licensed physician. As far as I know, it didn't specify percentages. In my research, I didn't come across any comment about whether or not a nurse practitioner could do the same. Physician dispensing. So this I want to spend some time on because it's fortunately a fairly unique problem to Texas. There are a few other states that prohibit it, but Texas is the one that's sort of the most glaring. And Texas Occupation Code 158.001 is the area that has this prohibition. And weirdly, you can give away samples if you get the sample directly from the pharmaceutical company. You couldn't buy them on your own and give them away. And if you're rural enough, which we're going to dig into here, you can go ahead and dispense. You're not limited the same way everybody else is. And it's designed to be, this law is just pharmacy protectionism. And that was built to allow you to do it if there's no pharmacy in the area. So here's the rural area discussion under Texas law. They say that, so first of all, you're limited to reimbursement for cost, so you can't mark up the medication. Most DPC physicians don't mark it up. You should still have the right to do that, and I think as long as you're transparent about it with the patient. But in Texas, assuming you were going to fit in this exception, if you're buying them from Andameds or some other wholesaler, you're going to want to pass it through at cost. How could you do it? Well, you'd have to find this is complicated, the section in yellow, but we'll go through it. You got to find an area, a county with a population of 5,000 or less, or a municipality that's got 2,500 people or less. So to simplify, a county of 5,000 or less, or a town of 2,500 or less that's at least 15 miles from a pharmacy. If you're relying on the town rule, the town of 2,500 or less, rather than the county rule, then you can't be right next to, I assume adjacent means 15 miles, but I'm not really sure. It just isn't clear how far adjacent can be. But you don't want to be next to another town that's got 2,500 or more. So I'm not sure how the Board of Pharmacy and Medicine are going to interpret that, or if they've ever been asked to interpret this. But the safest way, when I look at it, is to just say, all right, stick yourself in a quiet county that's got less than 5,000 people, and make sure you're over 15 miles from a pharmacy, and it should be a fairly ironclad argument that you would make. If you fit in this kind of situation, then you can maintain a supply of dangerous drugs in the physician's office to be dispensed in the course of treating your patients, and you can be reimbursed at cost. If you're doing this, I thought this was a little bit odd procedurally, but if you're going to do this, you sort of build your own argument for it, and you don't seem to ask for permission in advance necessarily. You just sort of start doing it, and then you notify both the Board of Pharmacy and the Board of Medicine that you're doing it. And then they can come in and peek and make sure they think you fit in this box. And then if you don't, I'm sure they will tell you that. I'd be a little bit fearful that if you made the news enough, somebody would stick a tiny pharmacy in your town just to make you stop. But at any rate, if you can't do that, then you're limited to a 72-hour supply, and you're really not doing much dispensing at all, or you're limited to free samples. If you can fit in the rural box, based on my research, and I've got some slides on this where we kind of look at the geography of Texas, you could probably do it if you're in one of the following counties. There are a few that I've highlighted there in yellow because I think they'd be harder because they have a population greater than 5,000. So I came up with this list of counties by going through here by hand. You'll see the way I did it in a moment, but I went and looked and said, all right, which counties in Texas don't have a pharmacy? And I made a list. And these are all the counties in Texas with no pharmacy at present. And then I said, all right, which of these counties has less than 5,000 people? Most of them did, which wasn't a surprise. But the three that did have more than 5,000 were Dallam, Delta, and Duval, 3 Ds there, which is interesting. All have greater than 5,000. So you'd have to rely on the town rule of 2,500 or less, and then make sure that you weren't next to another town or municipality that would mess it up for you. Coincidentally, of course, you could also pick a practice just across the border, and then you could dispense all you wanted. There are some legal efforts, and I'm happy to know that Chris Held is with us this evening, and Dr. Held may want to comment on this. I don't know if she'll have any updates she'll want to share, but she and Dr. Garrett worked with the Institute for Justice and tried to fix this on the legal side since the legislation wasn't getting very far in Texas. And they made a couple constitutional law arguments under this Texas Constitution. And much to my surprise, they lost at the district court level. And then that decision is now in the appellate phase. So the basis for those arguments is right there. Article 1, Section 19, which protects your right to pursue a chosen business free of unreasonable government interference. Or Article 1, Section 3, which says it forbids the state from drawing an unreasonable and protectionist distinctions between similar groups. And I think that's maybe the stronger argument of the two. But nonetheless, the district court apparently didn't like either one of them. This was from the Institute of Justice. They've got this as part of a video that's a 40-second clip that's worth watching later if you have a moment. But they did some research on their own and said, all right, let's try and see where all the pharmacies are and see where the rural doctors are and see if anybody can even dispense at all right now. And they concluded that 8 physicians could do that. I'm not sure who those 8 physicians are or maybe how easy they would be to find. Theoretically, if they're the only physician in the county, they should be easy. I did a little Googling and tried to find a few of them and couldn't find any obvious names, but they might be worth contacting. I'm not convinced that yellow dot on the eastern side of the state, probably on the Louisiana border, I'm not convinced they're far enough from a pharmacy, but some of the others likely are. So this was a map that I found on an ABC News page, and I'm not quite sure how they generated it, but it's really impressive and it's worth peeking at. Even if you're not in Texas, you can use this and you can zoom in quite a bit. And if you hover over these dots, this is across the entire continental United States and includes Hawaii and Texas, or excuse me, Hawaii and Alaska. You can see a little bit of Hawaii down there because they move it over near Texas. And if you hover over a dot, it will name the pharmacy. And you can see in certain cities, it's just very crowded, tons and tons of pharmacies. And in rural areas, you'll notice there are several counties in Texas where there are no dots. So that's what I did, was I hovered over to these counties and wrote them down. And those are what I included earlier in the slide deck, so you can see approximately where they are and make a good guess about being at least 15 miles from one of these, as you could potentially decide where to locate your practice. And then if you look at the distribution, this is from the Texas Tribune about where physicians tend to locate. There are several very dark counties. This is older. This is 2010. But where, at least according to their data, there wasn't a single physician. So if you think your patients are willing to travel to see you, or you find an area that sort of fits for any number of reasons and it's in one of those spots, I would encourage you to look hard at that. In my experience, rural medicine is quite interesting and rewarding. If you're not the big city type, patients often ask you to do more, which fits well with kind of a DPC mindset anyway. If you look at where practices are in Texas right now, out of the DPC mapper, I counted about 139 of them. And no surprise, they're where most of the people in Texas live. So plenty around Dallas, Fort Worth, plenty in Houston and San Antonio, and some a little further south as well, but not much in West Texas or in those rural areas. What about Texas Medicaid? So moving on from dispensing, Medicaid, I've got a page on this on DPC Frontier. There tends to be three different possibilities. Either they're really brutal, like they are in Kentucky and Colorado, where they really don't care if you as a physician are credentialed with Medicaid or not, whether or not you've signed a contract. Those two states say that you cannot privately contract with a Medicaid patient no matter what. And the only way to sort of privately contract with them is to make the argument, the losing argument in my opinion, that your practice does exclusively non-covered services, which is darn near impossible as a DPC physician to only do things that Medicaid doesn't cover. So assuming you're not in those states, and in Texas you're obviously not, then you either decide to participate in Medicaid and still build the argument that you can privately contract in certain circumstances, or you would decide to not participate, not be credentialed with Medicaid, and obviously retain the argument that you can privately contract because they have no jurisdiction over you. When it comes to Medicare, there's something called opted out status, where they still credential you and know that you're not going to bill. And the analogy in some states for Medicaid would be an OPRA status or OPRA status or OPR status. It goes by different names, where you're also credentialed with Medicaid and promising them that you're not going to bill. And the reason you would do that is so that they would still follow your orders when you do when you place a referral, when you order a lab, when you order a medication, and the patient wants it to be paid for through that Medicaid program. Texas, I've got a link to the manual that I found here, appears to allow physicians to build the argument that they could fully participate in Medicaid. In order to do that, they weirdly have to participate in Medicare. But assuming you wanted to participate in Medicaid and Medicare, could you fully participate in Medicaid and still privately contract for covered services? I think the answer is yes. Now, I'm not a Texas attorney. You've got to double check all this. But you've got section 1.7.11. Providers must certify that they will accept reimbursement paid for by Texas Medicaid for covered services and will not bill an eligible client for covered services. That seems to say, no, don't do this. But as you go a little further in their procedures manual, you come to 1.7.11.1, which says, if the provider accepts the client as a private pay patient, the provider must advise clients that they are accepted as private pay patients at the time the service is provided and be responsible for paying all services received. So this makes the water muddy when you put these two phrases next to each other, and it's a little bit unclear to me and maybe worthy of a question to the Medicaid department if you could get anybody to reply to it. So I think that's about all I have to say there. The rest of this is just kind of there for your reference. I don't feel the need to read it. And if you click the link in the procedures manual, say, okay, what does this agreement look like? You get a PDF document that is about the shortest one you'll find. This is the entire private pay agreement that's proposed in the manual right there. So it's really not an agreement so much as a statement that, hey, you got to pay for this. And if you agree and I agree, then okay. So surprisingly simple on its face. What does malpractice look like in Texas? Some states you have to have malpractice to legally practice medicine. Texas is not one of those states. It's not required. There are some non-economic damages caps that are in place. And some states like West Virginia, those caps only apply if you have malpractice insurance. I didn't seem to come across that particular rule in Texas, but these things are worth noting as you contemplate with your malpractice broker how much coverage you want to purchase. And then I've got an NCSL link down there where I found this information kind of aggregated, and it's also a nice place to glance at if you want to sort of compare Texas to other states. Sometimes these non-economic damages caps make a difference in malpractice quotes and what your rates are. Other times they don't. Other times they're often overturned. So even when you thought they were going to make a difference, by the time it's litigated to the state Supreme Court level, it doesn't hold up anyway. So Texas physician non-compete clauses, these were interesting. So, and this changed a few years back in Texas. So they've got a rule here that if you want the non-compete with a physician to be enforceable in Texas, you've got to offer a buyout in the agreement, and it has to be at a reasonable price. So it can't be some ridiculous buyout that's designed to intimidate and prevent you from actually going on to some other role that you think will be better suited for you. So the litigation here has been interesting. If the buyout's not there, if it's not in the agreement at all, then they don't tend to enforce the agreement. If it is in the agreement and it's unreasonable, then they may or may not enforce it, or that most likely it's going to go to arbitration, and then the arbiter is going to decide what a reasonable price is going to be, and that's what will be levied. So another slide kind of there for your reference, and I've highlighted sections that are kind of important. They can't prevent you from doing ongoing care. Some states, this has been an issue, so I'll sort of, I guess, use an example to drive that point home. If you're in a large hospital system with 50 family physicians and you decide you've had enough, you quit, you're going to go across town and work with the DPC doc that's already got a practice, and the hospital's bitter and angry about this. What will they do? Well, if they had a non-compete, they would try to enforce it. Assuming they can't enforce it, then you're going to keep working with that DPC physician in most states. And then to make your life a little harder, if their patients call and want to find out where you went, they'll say, we don't know, click and hang up. They might refuse to give you any of those medical records, even for a patient which you had an ongoing treatment relationship. Maybe it was a complicated cancer workup. And the way the hospital system would argue that it's not patient abandonment is, hey, we're big. We had 50 physicians. Now we have 49. The other people will pick up where you left off. And that's why the patient isn't being abandoned. So in Texas, that argument's not really going to hold up if you were to try to make it, because you've got this clause here in this section of the code that says, hey, you've got a right to continue to provide care in some way, shape, or form. You can have access to those medical records without a whole lot of red tape. Texas Medical Board, historically, I think they've gotten a lot more press than other medical boards. And if any of you have gone to very many AAPS meetings dating back a few years, Andy Schlafly has done lots of interesting work here and has had excellent summaries of litigation that AAPS was involved with, and he was heavily involved with, about sort of getting some transparency in the process here. And they've also made some news. I think the Dr. Death documentaries about the neurosurgeon who I think was around Dallas. There's some TV shows on it and some made-for-TV documentaries that show some horrible failure to stop a physician who was just harming one patient after another there, and the hospitals were involved in this as well. But anyway, the history here has been quite interesting. So in 2011, some of the rules were changed, and these were mostly oriented around giving some physicians due process rights when there was some sort of board complaint against them. So no longer could they be anonymous. No longer did you have this sort of unlimited time period with which you might be expected to defend yourself. You might get some anonymous complaint related to something 15 years ago to which you can't even access the record. So things were quite challenging before these updates were made. And hopefully you all will tell me you feel like they're better now. I have no idea if people really feel like this has made a difference or not. Okay. And then federally, what's going on right now? Not as much as has been discussed in prior years. There have been renewed pushes to fix the need to opt out. So physicians who decide that they want to privately contract with Medicare patients have to go through an opt-out process in order to contract for covered services. And for a long time, you had to remember to renew the opt-out every 2 years, or they would default you back in as participating, and then argue that all your private contracts were void and potentially subject to all kinds of fines. Now, once you opt out, you stay opted out unless you say you want back in. Before the COVID pandemic, you had a rolling 2-year window to come back in, assuming you didn't quit on the whole thing within your first 90 days. Now, during the duration of the pandemic, which I believe at the federal level is still ongoing, even though the pandemic emergencies have been largely lifted at a lot of state levels, at the federal level it's still in place. And what does that mean for opted out physicians? It means you don't have to wait for 2 years. If you want to get back in for whatever reason, you can do that at any point at the moment. There have been discussions about changing this opt-out necessity such that you could just privately contract with patients on a case-by-case basis, almost like the Texas Medicaid example we just went over, where it appears to me at least, based on that manual, the language there, that you could privately contract with Medicaid patients on a case-by-case basis. We would like to have the ability to do that at the federal level with Medicare patients as well. I have no idea if that will get any legs behind it, but there are some discussions there. And then there's the Primary Care Enhancement Act, which was designed to get rid of the HSA discrimination against DPC patients, whereby they could not join a practice and maintain an active HSA. Never mind use the HSA dollars to pay for DPC. So that's a longer discussion than what I had planned to get into here, because it's mostly a federal tax issue. And there's been controversy in the DPC community about how much support to give to pieces of legislation that come with some sort of cap on the monthly fee, which unfortunately that one did. It was kind of a hold your nose situation, and hopefully see that cap increase over time. Some other bills were offered that didn't include the cap, but they had less bipartisan support. So we'll see if that picks up again this year or not. There's also been a Veterans Access to Direct Primary Care Act, which was designed to create a 5-year pilot program within the VA system that would say, hey, we can't provide all this care that we need to provide to our VA patients anyway. What if we said to them, pick a DPC practice in the community and then turn around and turn in your monthly invoice to us, and we'll pay you back for part or all of it, depending on the price. That's my understanding as to how that language was worded. And unfortunately, it hasn't had much discussion at the federal level beyond when it was initially referred to the House Veterans Affairs Subcommittee on Health. So that's my prepared talk today. And we can switch to Q&A, assuming there are questions or a desire for additional discussion.
Yes, absolutely. I do think Dr. Held wanted to comment on that appeal situation I'm going to attempt to bring her on stage so she can give us more background information on that. Okay. It looks as she may have. Okay, let's see if this works.
Okay, can you hear me?
Yes.
Okay, great. Yeah, Phil, thanks for your excellent talk. Oh my goodness. But yeah, we thought we were going to really win that case. We brought that case, as you know, because every 2 years it would go before the legislature, and on the eve of it coming out of committee, the pharmacy interests would always beat us out. And so IJ, Institute for Justice, was gracious enough to do the case. We really thought we were going to win the case, and then it went on appeal, and then COVID came. We've literally been on appeal since COVID, waiting. So we're still waiting. I still have hope. But we were told last session, because it was, still in litigation, not to spend as much time on the legislation. But I think we need to go ahead and fight for the physician dispense on the legislative front, and then just pray and hope and go forward with the appeal. I'd love to hear what you guys have to say on that.
I would agree with you. I think you push on all sides. In Montana, they did something similar. Institute of Justice was involved up there too, and I don't know if their case was going to move any quicker than what you guys are facing in Texas. But when that stuff came before the legislature, I guess maybe the pharmacy lobby they were much more honest than I think what you've dealt with in Texas. And they said, you know what, this is protectionist and we don't need to keep this here. So they didn't oppose the bill, and the bill passed, and the lawsuit became moot. So, but I think part of the reason it did get support at the legislative level was they saw the lawsuit sitting there and realized how silly it was. But unfortunately, I suppose that hasn't happened in Texas. Although maybe you'll tell me my timing is off. Have you had a legislative failure since all of the lawsuit language was public and discussed broadly?
We really haven't. The committee that it would always go through had a chairwoman that for some reason was just unfavorable. And even though there were votes on the committee to pass it, she just would not bring it out of committee. So I think it's worth a try again. They're different. I thought that with the COVID, that would be really help our case and say, oh my gosh, we need to get physicians out there prescribing and dispensing from their office. And then, of course, we know what happened to early treatment. So, we'll see what happens. I'd love to see people in this group contact their senators, state senators, and state representatives to really get going for next session to do this. I think we have to.
Well, that's a big one. I guess, do you guys happen, I don't know if it's worth pulling up the geography again, but if you happen to know anybody who's located in any of those counties and would be willing to, do some dispensing, I think that might make it interesting too. Because you could see that it's already working well, and it's working well in Texas, and there haven't been bad outcomes, and you could start showing some savings data and that kind of thing.
Dr. Roger, you have a question?
Yes, I do. So you got my attention, Dr. Askew, when you were talking about how it seemed like Texas didn't like for DPC docs to be doing any treating of injured workers. Was it my understanding that that's the way that they want to leave it, or is it okay if DPC docs do treat injured workers that are on a DPC program sponsored by their employer, as long as they that injured worker is reported through a $0 claim?
I can pull that up again. I can do a screen share if you want. Let's look at the language together here. Share screen. Screen 2. Okay. So you should see the code again there. Let's go to that section. So it's very brief. And it just says, this subchapter does not apply to workers' compensation insurance coverage as defined in the code. So they've specifically said that everything you're doing in the DPC agreement isn't within regular health insurance, isn't a risk-bearing entity. But then they're coming out here and saying, don't include the workers' comp. That's how I'm just, reading this first glance. And I don't know. I guess I can't answer your question with certainty. My general comment would be maybe they're okay with you ghost claiming, but it sounds to me like they want to see some sort of billing there, and they want to be able to track it. Mm-hmm. And they won't let you kind of work it in on any kind of capitated basis, because that's how the workers' comp's designed. I know in some states you can only buy workers' comp insurance from the state, and I don't know what it's like in Texas if you have a lot of private plans. And if you do have private plans, do those plans have some autonomy to come up with some sort of de minimis capitated plan that would mimic DPC, where there's some sort of PMPM right alongside the regular DPC PMPM, so that the whole thing is sort of smooth?
It's really interesting, because I've talked to certain employers who have work comp insurance with major work comp carriers in Texas, and they are okay with these employers treating injured workers on a pre-claim basis, and they've actually gotten like rebates from the large work comp carriers because they've kept the volume down. But then it looks like the way that this is written is, okay, an employer can't treat injured workers on a capitated basis, which is kind of like DPC is.
Yeah, I think I guess what I would say is you might be able to do it capitated. I've not dug into the entire workers' comp code in Texas. What this seems to say is they don't want you lumping it into the same capitated fee for DPC. Oh. So if you were going to charge, if you got a contract with an employer and you and the employer said, hey, 90% of our workers' comp is this easier things that we think you could handle in your office, and the other 5% that you can't winds up going to ortho, and the other 5% goes to neurological surgery. So we want you to do the 90% you can do, and we want to pay you approximately $10 per member per month to do that component of it, and $90 per member per month to do the DPC fee. Then I think the state's probably fine with that, but you'd have to read that section of the code. If instead of doing it that way, where you put them alongside each other, if you said, no, we're going to do $100 and we're going to lump in the workers' comp and the DPC as the same one, once a month fee, then that's when I think they might look at this language and get irritable with you, because they have no vision into what was siloed into workers' comp. So I don't think they're saying, no, you can't do it. We view it as a conflict of interest. I think lots of family physicians do workers' comp all over the place. So it's not that you couldn't deliver the care. It's just that they don't want it lumped in that exact same monthly fee. That's my reading of it.
Interesting. Thank you for bringing that up and for your comments on that and the great presentation you did tonight.
Oh, thanks, Roger.
Awesome. So we do have more questions. Dr. Altamirano asks, what is the advantage of opting out of Medicare? If we PRN add an urgent care or ER, will it limit our employers' ability to bill?
It certainly can. So when you're dealing with Medicare, you're either all in or all out. And if you opt out, then the chance for you to bill Medicare patients is very restricted. There are a few exceptions that you can look to. The most obvious one is the ER urgent care exception. There's a coding modifier you can add to those claims where they get paid at the non-participating physician rate, which I think is either 90 or 95% of whatever Medicare would have been paid. And then all of your orders are still followed. So theoretically, an ER shouldn't care too much because most of their money is made on the ancillaries, not on your billing. I've had a few physicians tell me that they made these arrangements with some smaller hospitals that were willing to play ball and do this, only to find that the Medicare carriers that were processing the claims, the MACs, were messing it up so often that both the physician and the hospital sort of gave up, even though they were legally right. It became such a hassle with the MACs that don't know their own rules that they kind of gave up on it. So the reality is, while that might be allowed, I don't know very many people that have managed to pull it off, and most hospitals don't want to deal with it. So if you opt out, you probably are not working in those settings unless they're big enough that, if you worked at a massive urgent care, maybe they could intentionally just not assign Medicare patients to you, but or at a hospitalist service or something else for that matter. But most of the time, it's going to keep you from moonlighting in those settings. So what people tend to do if they're trying to run a cash pay practice of any number of varieties is they might still work outside their practice in these settings, and they build a wait list of Medicare patients. And as their private cash pay practice grows, eventually they're going to want to ditch their moonlighting. And then when they ditch their moonlighting, they've already got a wait list of Medicare patients who want to join the moment they opt out. And so they do it that way.
Thank you. The next question from Dr. Saravia. Just to clarify, if you want to treat someone with Medicaid, they have to sign a form like the one you posted?
That's what Texas seems to say. And there's a separate, I've got a separate page on DPC Frontier that we could walk through too, if you think that'd be helpful. That's specifically about Medicaid, and it outlines these different statuses that you can have with Medicaid. So most states, the answer is that OPR status, where you get credentialed with them, but they know that you're never going to bill them and that you want to be able to bill patients for covered services on a private contract basis. And in Texas, I'm not convinced right now that you have to go through that. You might be able to privately contract on a case-by-case basis from what I read.
Thank you. One more question by the same person. Whoops, got to show that. Also, can you clarify the type of discrimination seen by a hospital, and would that include a private hospitalist group?
Sure. So if you're trying to follow your patients into the hospital, then the hospital could make credentialing difficult for you. They could refuse to credential you for any number of weird reasons. Maybe they're going to say, well, you wouldn't take call from the ER when you didn't want to have random patients assigned to you from the ER. So now they're not going to credential you or let you round on your own patients there. Especially in the age of COVID, they might not want to have anybody in the hospital who doesn't have to be there, which was understandable for a time. So that even those courtesy visits would become difficult, even if you didn't have official privileges. So yes, DPC physicians have faced this. Any number of private pay physicians have faced this, and it can be a challenge. So if you can prove that they're doing that just because you're a DPC physician, then you might have an interesting case of discrimination, you could argue, in Texas. The other place you would look to, if you're trying to prove that it's based on your DPC status, is what the hospital's bylaws say. And if their bylaws have some sort of weird clause in there that puts in writing that they're maybe, they're probably not that dumb, but if they're dumb enough to put in writing that they don't want any DPC physicians credentialed there, or don't want any private pay physicians credentialed, then that might work in your favor too.
Okay, thank you. There are no questions left, but I will give everyone a moment. There is a raise your hand feature. This is the last call if you want to come on stage and share a few comments. Okay, so where can people find you, Dr. Askew, if they want to reach out to you for any sort of collaboration?
The best way to reach me is email, and it's PHIL Phil@dpcfrontier.com.
Thank you.
Mm-hmm.
Well, I want to really thank you for, again, breaking all of these things down and taking the time to do the research for a state you are not actually practicing in. And it's really a servant mindset, a servant heart. And this is what we all need to continue this movement. I'm going to post a quick poll to let's see if I did that right. No, I did not. Okay, it's not for today. Basically, if you thought this was helpful, definitely message me on LinkedIn. And if you have future requests for topics, messages, and also improvement suggestions. Take a last look at the chat. No, I think there's nobody who has any further questions, which takes us to the end of this live presentation. I think it was a very great success. At a peak, we had 20 live viewers. This is recorded. This will be shared to the FMMA's YouTube channel. And I do think Dr. Mochigema wants to announce the next meeting, so I'm going to bring him briefly on stage, and after that we will release all of you to your well-deserved evening. Thank you again, Dr. Askew, and see you very soon.
Thank you, Shankar.
Okay, I was just trying to send you a reminder. Our next meeting will be the first Thursday in July, and we're going to be talking about the Consolidated Appropriations Act, which is a big deal for employers. And as you know, that's a big part of what we're trying to pull together here, that community of employers. A lot of employers don't know about it. We have an excellent speaker on deck that will be presenting. So everyone try to pencil that in on your calendar. Thank you again, Dr. Askew, for tonight.
Absolutely, Dr. Roger. I will create that event within the next week, and then people who like to be early birds can purchase those tickets. And also don't forget to sign up as a free member, San Antonio FMMA.org. That's it for tonight. Thank you all for attending, and we'll see you next month. Bye-bye.
Bye.